thank you everybody for having me today. So my name is Pieter De Vlieger, and I'll be presenting my paper, which is called Quantifying Sources of Persistent Prescription Behavior. And I'll actually be focusing on evidence from Belgium using a unique policy experiment and some pretty nice data. So the motivation from this paper really comes from the fact that policymakers want to essentially make efficient use of healthcare dollars, especially in the wake of increasing healthcare costs. And so, for instance, one way to do this would essentially be by replacing expensive treatments with cheaper, equally effective ones. And a really important hurdle that policymakers essentially have encountered is that physician behavior is actually highly persistent and difficult to change. And a very good example of this is actually the prescription of generic prescription drugs. So these, in theory, provide the same therapeutic value as their generic counterparts, as their branded counterparts, but they're actually cheaper. And even though this is a pretty nice feature to have, a lot of papers actually have shown that adoption of these prescription drugs has been very slow in a number of markets in a number of countries using different medications, essentially. And as a result, essentially, large possible cost reductions actually go unrealized. Right? And so a pretty important puzzle actually is that we don't really understand the drivers of persistence all that well. So there's really two strands in this literature. And so the first strand, really argues that this is about physicians, right? So physicians might have preferences, industry interactions, and habits, and as a result, they don't really act as a perfect agent for their patient or for the healthcare system, and essentially prescribe the more expensive prescription drug. Now, there's also another strand of the research that actually argues that maybe patients actually have some switching costs, right? So there's a couple of recent papers in economics that actually have focused on patient willingness to pay for brand name drugs. So I actually think Ben Shapiro and Alyosha Janssen have a paper on this. But there's maybe also some behavioral biases that would explain this. So there's actually a pretty active strand of research in the public health sphere that kind of focuses on essentially that maintaining the same drug over time might actually make it easier for patients to essentially adhere to their medication regimen. And that might actually be an important factor. Right? And so in the paper, I actually refer to the first as physician bias, but I want to make it very clear, I don't take a strong stand on what exactly is driving this. I just refer to this as a propensity to prescribe a brand name drug when you normally shouldn't really do this as a perfect agent. And then the second strand I will refer to in the paper as patient considerations, right? So essentially the physician takes some factors of patient demand essentially into account. And the empirical evidence on their relative importance is actually fairly limited, even though this has some pretty important implications for who policymakers want to target. And it also has some pretty ambiguous welfare implications, especially if some of these behavioral biases and these medication adherence effects are actually pretty important, right? The two key research questions in this paper are essentially, what is the relative importance of physicians and patients in prescription decisions of primary care physicians? And what drives persistence on the patient end, essentially? And so what I'll do is I'll exploit the Belgian healthcare market as a pretty ideal setting to really try and measure these things. And so just because most people in the room here probably are not from Belgium, I kind of want to highlight a couple of key features of the healthcare market in Belgium. So Belgium has a multi-payer system with single universal insurance coverage. And this is really going to eliminate plan choice and outside options at the patient level. And at the same time, physicians don't really have any uncertainty over the patient copay or the healthcare plan they're on, which is a very nice feature, and it allows me to not take into account a lot of uncertainty that might be existing in other healthcare markets. At the same time, direct-to-consumer advertising for prescription drugs is actually not allowed in all of the European Union. And there's actually also some survey evidence in Belgium that actually suggests that patients actually rarely request generics from physicians, and a few can actually tell a brand name drug from a generic drug. So for the most popular prescription drug in Belgium, only can actually tell which is a brand versus a generic drug. At the same time, detailing or marketing to physicians is actually highly regulated. I don't want to rule out that the industry interactions do exist, but to the extent that they do, the policy experiment that I'll actually exploit, pharmaceutical companies actually can't really respond to it that much. I have more about this in the paper if you're interested in finding out about this. And I think also a pretty important feature here is actually that patients don't really have a lot of say in the final product they actually get. Physicians actually prescribe on product name, so they actually need to write down the brand name of the brand name of the drug, right? A generic versus a brand name, and there's no pharmaceutical substitution at the pharmacy level. So prescriptions will actually capture physician behavior, right? Which is a very important feature, which is not easily replicable in other countries. So the specific policy experiment that I actually exploit in my paper is a minimum prescription rate. And so as most countries in the early 2000s, Belgian policymakers actually saw that prescription drug spending was rising faster than overall overall healthcare spending. And at the same time, there was a very low take-up of generics in Belgium. So in 2004, it was about 12%. And so the policy response was actually for policymakers to mandate a minimum prescription rate. So they actually required physicians to prescribe a minimum percentage of cheap drugs. And this was essentially uniform at the specialty, right? So essentially, primary care physicians had to prescribe a minimum of 27% of cheap drugs. And cheap drugs are generics are brand name drugs that match a generic price. And in 2004, brand name drugs that matched the generic price only account for about 4 to 5% of the market share. So that's actually a very small number. And if this was not met, there were some, they essentially had to justify their prescription behavior at the order of physicians. I can discuss this in a bit more detail, but this would essentially be the penalty they face if they don't stick to the prescription, to the mandate. And so the timing of this was that this was pretty actively discussed in medical circles in May and June of 2005, and finally announced in July of 2005. And so this actually went into effect in January of 2006. So the data that I used to actually measure the effect of this policy essentially draws from transaction data in the universe of pharmacies. And so essentially in pharmacies, all prescriptions that are filled or the barcode is scanned by the pharmacist, and essentially from this data, I essentially get product identifiers, physician identifiers, and patient identifiers, along with the exact copay and reimbursement at the patient level, right? So what I do then is I draw 300 random physicians, and I get the full history for all patients 35 years and older for the years 2004 and 2009. I want to make it clear that the sample selection is not a random thing that I just did for the purposes of my study. I actually asked for this data at the time of GDPR in Belgium, and I actually had to provide a power analysis to get the minimum number of patients to actually do a qualified study, and these are actually the numbers I ended up with. So this is not just a random sample selection, essentially. So what I do then is I use the patient and physician identifiers to merge on census and vital statistics. So I get some demographics of the patients and the physicians. Then I also merge on product data using the product identifier. And then this provides me essentially with the final sample. Okay?
Peter, you've got two clarification questions. We don't normally interrupt, but because it's the Belgian system and we're not familiar, I wondered if you could provide this detail about what on product means and this.
Okay, so there's a couple of different essentially also generic producers in Belgium. Typically, for instance, like if you want to prescribe Zocor generic, you would essentially need to draw, for instance, like an important producer of generic drugs in Belgium is Eurogenerics. And then it would essentially need to write down Eurogenerics 5 milligrams, a box of this many. So that is essentially what would happen. So there is some out-of-pocket payments for the patient. Typically, they pay about 25% of the overall cost with a maximum bill. So I discussed some of this in the paper in more detail. But by and large, essentially, there is some skin in the game, essentially, for patients to want to get the cheaper drug. So the way the sample construction then works is I essentially have 26 million observations with some patient characteristics, and I will focus on prescriptions for chronic conditions, by and large, because these are really where like the key questions that I'm answering have the most bite. At the same time, they also represent about 85% of prescriptions in Belgium and in most countries, actually. So I would actually define a starter as a patient who receives their first prescription of an active ingredient less than 90 days ago, and long-standing patients as those that have been using an active ingredient for at least 90 days. Then I also set up two important measures that I want to discuss. The first one, which is polypharmacy, and this is the number of chronic prescription drugs that a patient uses in a single year. And similar to most other countries, you actually find that older patients tend to take a lot of drugs at the same time. And then I also set up a measure of medication adherence where I actually look at the daily doses a patient gets at time t. And then I essentially measure from the pharmacy transaction data, where I actually have the date of the transaction, how long this box will actually be used by the patient. Okay? And so essentially, if this measure is close to 1, it suggests a perfect adherence, and if it's below 1, there's imperfect compliance, essentially. Okay, is that clear for everybody? Okay, so it's a bit harder to read the room when things are on Zoom. And so essentially the main results I have are the following. So I have some event study estimates, and I actually find that if physicians increase the use of generics, but primarily among starters, so they actually increase on a base of 35% their prescription of generic prescription drugs by about 10 percentage points, but they're much less likely switch long-standing patients, actually. So they only increase the rate at which long-standing patients are switched by about 1 to 2 percentage points. So to just give you a graphical idea of what this looks like, the orange line here is essentially the prescription rate of generics for these first-time patients. And then the blue line essentially is the change in generic prescription rates among these long-standing patients. And so what I do want to highlight here is that on the x-axis, we see quarters before and after the announcement of the mandate. And as I highlighted before, this was pretty widely discussed in medical circles, and you do see some anticipation in this first quarter just before the mandate is announced. And this is essentially picking up some anticipation on the physician end in May and June of 2005. Right? So at the same time, what's pretty important to note here is that in order to essentially prescribe more generics for these first-time patients, physicians don't move away from using on-patent drugs, right? So rather than going from Lipitor to generic Zocor, physicians are really going from a brand name drug, for instance, the brand is Zocor, and then they actually go to the generic equivalent of Zocor, right? So they really essentially make sure that the patient receives the same molecule. And I actually have a host of other quality dimensions as well. There's no change in the use of extended release formulations, no change in the use of administration method, and no change in the strength of the prescription they essentially end up prescribing, right? So that's a pretty nice result, and essentially highlights that physicians could have done this before the mandate, but essentially didn't do it, at least for these first-time patients. And so this is just the event study for the on-patent drugs. So if anything, we actually see that the use of on-patent drugs even trends up a little over time. But I do want to highlight here, if you look at the y-axis, this is between 2.5 percentage points and 2.5%, minus 2.5 percentage points and 2.5 percentage points. So even though we see a bit of a positive slope here, it's actually a fairly small slope. But so if anything, this policy definitely didn't move physicians away from using possibly superior on-patent drugs. And I have a link to some other quality dimensions as well, if that's useful. And so one thing then that I also want to highlight, but I won't discuss in more detail, is actually the fourth point here, is that physicians are actually particularly unlikely to switch older patients using multiple prescriptions, right? And so these are actually the patients where we might expect that switching one prescription drug might actually generate some confusion. If an old patient is used to taking a yellow pill and a blue pill in the morning, a yellow pill in the morning and a blue pill in the afternoon, they might actually get confused when they suddenly get a green pill and a red pill, right? And so in order to actually answer this question, I would actually use an instrumental variable approach, where I would actually look at whether switching a patient's prescription will actually decrease the patient's medication adherence. And so because I actually have enough time, I will actually discuss how I set this up in a little bit more detail. But essentially the key question I'm trying to answer here is, does switching a patient's prescription drug, even holding the active ingredient constant, actually affect health? And the proxy that I'm going to use as a health outcome is essentially adherence. Essentially what you want to do is you want to regress some adherence measure on essentially a switch. But what we would be worried in if we just run this as a cross-sectional regression is that the switch is actually endogenous, right? So like a physician will only switch a patient if the patient is actually willing to do this, or whether this is actually a good candidate for switching, right? So what I end up doing is, in order to deal with this endogeneity concern, I would actually use an instrumental variable approach. And essentially what I do is, the IV I use is whether the patient visits a high or a low prescriber post-announcement. So essentially what I'm doing is I'm comparing the adherence of a patient who visits a physician far from the threshold, and I compare it to the medication adherence of a patient visiting a physician close to the threshold. And those further from the threshold are actually much more likely to switch their long-standing patients. That is something that I actually also discuss in more detail in the paper. And there are two restrictions, or two assumptions here, that I want to discuss in a bit more detail. And so the first is essentially the exclusion restriction. So essentially this argues that the physician's ability to manage adherence is actually independent of whether the physician is a high or low prescriber. And I actually do some things in the paper to verify this assumption, and at least like the data seems to support that assumption. And then the second assumption is that I actually want to highlight that I use cluster robust first stage F statistics, where I cluster at the physician level, essentially. And I'll just show this graphically, because I think it's the best way to show it. Essentially what we find is, at the time of a switch, so essentially the patient gets switched, essentially uses their typical prescription drug at T-1. And then when the patient picks up their new prescription drug, we actually see that their medication adherence drops by about 0.3. And you can actually back out from the data that essentially means that where a patient typically picks up their prescription every 2 months, they now actually only pick it up after 3 months. So there's a change in medication adherence of about 1 month, which is quite high, but at the same time, you do see that these effects actually do not persist. So during the second switch, the implied change is actually only half a month. And then actually things go back to normal. So there's really this kind of adjustment cost that patients need to pay to essentially know which pill to take when. I do some additional robustness checks in the paper, actually, to make sure that this is not driven by hoarding, right? So for instance, like maybe some patients had some pills lying around at home. That's not really what I find in the data. At the same time, I also want to highlight that the first stage F statistics actually look pretty good. So by and large, if you kind of take everything together, what I find is that physicians essentially increase the use of generics for first-time patients without compromising on quality. They're much less likely to switch long-standing patients, especially if they're old and use multiple prescription drugs. And I do find that switching a patient, even with an active ingredient, would decrease their medication adherence. What I also want to highlight here is that the IV is actually lower than the OLS, which does suggest that endogeneity in a simple regression actually would be a concern. Now, to actually try and quantify just how important these effects would be, I actually set up a simple model of a physician prescription decisions, where physicians actually maximize the utility of prescribing a product K, given a previous choice K prime. And essentially, physicians are altruistic in the sense that they take into account the patient's copay, but they also derive utility from essentially prescribing a brand name drug over generic. And so this side term actually captures this, right? And then at the same time, because I find that these switching costs are actually fairly short-lived, I actually model the switching cost as a fairly one-time cost at the patient level. And then essentially there's like some idiosyncratic error terms that essentially also are tagged onto the utility, right? And so essentially what I then end up doing is I model the mandate as essentially an effort problem. And I actually show that in response to the mandate, physicians will actually adjust their XI bias term to a new level, where they actually decrease their bias in favor of prescribing more brand name drugs, okay? And so then actually I estimate this. Let me quickly check the question just in case there was a, okay, nothing. So let me then just quickly discuss, yes, okay, and so I estimate this using conditional logit regressions, and then I actually end up using the estimates to essentially see how long it would take, how the adoption of generics actually runs out over 5 years, depending on what I actually allow to end up affecting physician behavior. And so the solid blue line here in the bottom essentially has copay included, physician biases included, and these patient switching costs all included, right? And what we see is that when only physician bias actually enters the physician bias and copay enter the decision of the physician, I actually find that after about 5 years, we end up with a market share of about 60%. But what I also find is if I actually don't allow physician biases to enter the decision of a physician with only these patient switching costs, I actually find that the adoption of generics is substantially lower. And it actually takes about 2.5 years before the adoption of generics actually exceeds the adoption of generics if only physician biases matter. And after about 5 years, essentially the market share is also about 60 to 70%. So at least on the medium run, where the medium run is defined as 5 years, I essentially use this picture to argue that physician and patient factors are actually about equally important in explaining the slow adoption over this time period. At the same time, I want to fully acknowledge that if we would have this run out over 20 years, of course, these physician factors would end up being more important. But I do want to highlight that there's some pretty important adjustment costs essentially at the patient level that could be pretty important. So an additional kind of facts what I actually do, and I think I have enough time, so actually let me go through the setup, is I actually assume that that the transaction utility that I use in the structural model actually reflects health. So I want to be absolutely clear that I'm very cognizant of the fact that this is a pretty strong assumption, right? Because this is essentially the physician's utility and not necessarily the patient's health utility. What I do use is I essentially set up here in the third bullet point, I set up the budget of the healthcare system in Belgium. And then I actually use the patient's compensating variation extracted from the transaction utility to measure their health essentially. And what I do is I actually end up taking out the physician bias term. I want to be absolutely clear that I understand that this is a pretty strong assumption, but I just want to highlight that if we make this assumption, essentially how important would these things really be in the short term, right? And then I essentially allow the social planner objective function to be a weighted sum of both these costs on the budget side, but also the patient welfare on the patient side, right? And then let me just go back and then just essentially explain what this picture is telling us. So on the x-axis here, we essentially have the weight on patient welfare. So if this weight on patient welfare is 0, the policymaker only cares about the costs in the healthcare system. And then obviously introducing a mandatory generic substitution scheme where pharmacists are actually required to dispense a generic whenever a physician prescribes a brand name drug, obviously leads to a welfare gain, right? So this is here positive, and then a healthcare system would always want to do this. But what we also see is that as the weight on patient welfare actually increases, there's actually a point at which overall welfare actually ends up being negative. And so the minute healthcare system actually weighs these costs about equally, we actually find that the generic substitution scheme in Belgium at that point in time essentially would have been welfare reducing. And I also use the actual policy to try and back out to the actual weight that the Belgian healthcare system puts on patients. And I actually find that it is about 71 to 72%. And if we take this weight seriously, we would actually need to decrease patient considerations by at least 60% for a mandatory generic substitution scheme to actually be beneficial from a society point of view. Another way to interpret this result is actually if we think that there's a patient willingness to pay for a brand name drug that I discussed earlier on in the motivation is actually important, and the stickiness I'm picking up on the patient side is actually a weighted average of both like this willingness to pay and these actual healthcare costs resulting from imperfect compliance on the patient side. We actually need to we actually need this willingness to pay for a brand name drug to be at least 3 times higher than like patient consideration, right? So like we essentially need like this willingness to pay to be substantially higher than these medication adherence facts for this policy to actually make sense, right? So then just to conclude, so what I do in this paper, I essentially study the interaction between physician and patient behavior, and I exploit a large policy mandate with some institutional features to really argue that what I'm capturing in the data is physician and patient behavior. And what is also a very nice feature is that I actually use a large representative data set. So this actually has 2 really nice features. A lot of papers that have focused on physician biases tend to use patent expirations of some pretty small prescription drugs, where it's maybe not always a very important drug for both for the patient and for the physician. I actually use a full scope of what a physician typically prescribes on a daily basis, and I actually find that most of the effects that I'm picking up is actually from pretty important prescription drugs, such as ACE inhibitors, diabetes drugs, etc. At the same time, this is actually also one of the first papers to actually use a large representative data set to measure medication adherence effects. Although I do want to highlight there's definitely some other ones that have done this. But at least in the US, often these studies are pretty small in terms of geographics and in terms of the actual data set they have access to. So what I do with this data and this policy experiment is I actually provide reduced form evidence that there is some physician bias in the data, but that there's also some pretty important patient considerations. And what I actually show is that this latter is at least in part driven by medication adherence. And again, here I want to argue, like, I'm fully cognizant of the fact that some of these willingness to pay factors might actually also come into the picture, but I do show that medication adherence is actually also maybe actually a facet physicians take into account. And this is actually one of the first papers to do so. Then I actually use a structural model to quantify the relative importance of both of these factors. And essentially what I end up finding is that both factors are actually quantitatively pretty important, at least on a 5-year timeline, in explaining the slow adoption of generic prescription drugs. And I actually find that welfare and fiscal implications for popular, often healthcare used policies, for instance, mandatory generic substitution in pharmacies, is actually not as clear cut as they're often made out to be. And that actually the continuity of care and how chronic patients actually use their healthcare is actually something we don't fully understand that well, and is actually pretty important in explaining a lot of the stickiness that we see actually in healthcare decisions. And I think that's my presentation. So I'll end it up, I ended a bit early, so we can have an earlier weekend then, and I'll wait for the discussant, and I'll happily take some questions at the end of this as well.
So thanks for the opportunity to review this paper and share a couple of my thoughts. With it being so close to the end, I think we'll just jump right in here. There we go. This is an incredibly ambitious project that has broad implications for health and health policy. My interpretation of the big picture question is why physicians exhibit persistence in prescribing brand name pharmaceuticals and what the costs, both financial and health, are to mandating increased generic drug prescription rates. My understanding of the 2006 policy shift is that it was largely flexible outside of the requirement to increase the rate of generic prescriptions from 18 to 27%. but it allowed physicians the latitude to determine what they would or how they would meet that requirement. And most physicians implemented sharp changes to their prescribing behavior. So Peter breaks up possible mechanisms to look at whether physicians exhibit bias, such as existing habits or preferences or even financial incentives to prescribe brand name drugs over their generic equivalents. He finds evidence of physician bias as physicians increase their generic prescription rate post-policy shift. But like he pointed out in his presentation, he's not really taking a stand on like which one of these factors is contributing to the change in generic rate prescriptions. He also acknowledges that patients have preferences, and he operationalizes this idea by studying the adherence measure, finding that adherence drops by about 30% and is most prominent in aging individuals with multiple prescriptions. So physicians are forced to weigh these two components, and his final contribution is using a structural model to parse out the relative importance of these two empirical considerations. This is an incredibly important topic with very wide-ranging implications. Of course, in the US, we're still in the middle of the debate on how to rein in healthcare costs, if a national level system is desirable, and if so, what features it might offer. Peter does a great job of emphasizing the uniqueness of the Belgian context, but I think these sorts of studies are nonetheless important to policymakers like the US and others who are grappling with how to control pharmaceutical costs and healthcare costs more broadly. I think you're absolutely correct to be careful to frame your results within the unique context of the Belgian market. And I'm sure you've thought about these broader implications outside that narrow context, but I would also consider mentioning some of these, of course, with caveats in the paper. I also really wanted to commend you on your first paragraph. As someone who does not study physician behavior, pharmaceutical markets, or anything really related to that, you were just very successful in immediately grabbing my attention and convincing me that this is an incredibly important topic. The agenda of your research project, though, is probably too ambitious for a single paper, which again, I'm sure that you've thought about. I would recommend breaking it up into at least 3 separate papers. Just as a quick concrete suggestion, I think there's a natural divide between your first 2 research questions versus your second 2 research questions in the structural modeling. The ambitious format you currently have, I found a little more challenging to follow, but I think breaking up your ideas into these more digestible components will serve to consolidate those ideas and keep readers engaged and following the story that you want to tell. So along those lines, I think you need to think critically about what elements are really essential to your story. You have a limited amount of space to engage readers as you lay out your issue, the background, how you're going to address it, and what your analysis is going to show. In particular, I felt the methods, results, and discussion in the empirical question parts were each very, very brief, and they were kind of meshed together. I think fleshing these sections out with more details would be very helpful to telling your story. For example, one thing that that would help clarify the specifications would be to explicitly state like the unit of observation, which I assume to be the patient drug level, and also listing what controls you're using in each specification. I think some of this information was in like table footnotes and stuff, but I really think that deserves to be in the main text. On the flip side, for space considerations, if you need to drop some things out, I think something that you could do without is maybe the details on how prescriptions are filled in Belgium. But others might disagree. There were some clarifying questions on that in the chat too. So the identification strategy here is really solid. It's clean, exogenous. It's a great use of a policy shift to examine physician behavior. Like I said before, you've done a great job highlighting the uniqueness of the Belgian context. Universal healthcare, no direct-to-consumer advertising, pharmacists being prohibited from substituting generic and branded drugs, and all of these characteristics play in really well for your identification. I also really liked your attention to alternative mechanisms that could produce the rise in generic prescription rates among physicians. The one question I had in the back of my mind, and perhaps I missed it in the paper, but is whether there might be modifications to physician behavior on the extensive margin and what sort of implications we should be thinking about there. So meaning I'm thinking there's a regular flow of starters, chronic condition starters coming into the system, but what if physicians responded to the policy shift by simply writing more, mostly generic prescriptions for conditions that they previously would have suggested an over-the-counter remedy or no remedy at all? So I'm thinking if this were the case, the total costs of pharmaceuticals to society could continue to climb, even as the generic prescription drug rate increases. If there were some sort of behavior modification along these lines, which there may not be, then I would want to think more about whether this is welfare enhancing for the individual and society. Is the prescription medication something that improves life? Maybe it decreases the individual's pain, or is it over-medicating to meet the external requirement of the generic prescription drug rates? The rest of these comments are just more of a list of questions, all of which I think would be easily addressed with breaking up the current format into several separate papers that have the space to really flesh out the methods, results, and discussion. So first, I was wondering if it might be appropriate to use patient-physician age as a control for prescribing behavior. I'm thinking your results show, and I think you may include this as a control in some of the research questions 3 and 4, that patient age matters for the decision to switch between brand named and generic drugs. I was wondering if physician age is not also part of the controls, if that could also matter, as I'm kind of thinking it could be related to like formed habits that they have or something like that. In the 4th specification, I wasn't real clear on whether starters were the reference category or if non-chronic prescription users were in there somehow. There was also reference to switching a chronic starter at some point, but I might have misread something there, but I was confused by that a little bit, because to me the switching kind of implied having already taken the medication or the active ingredients, which then would preclude starting. The IV in questions, your research questions 3 and 4, the FSTAT was plenty high, of course. I was a little confused with the language earlier suggesting that relatively little switching occurred as a result of the policy change, but I think your presentation clarified this a lot more here just a couple minutes ago. Yeah, so that's pretty much it. Thanks again for the opportunity to comment on your paper and to read it, and best of luck as the paper moves forward.
Okay, thank you very much. Can you maybe just leave that up for just a second? So I do want to highlight that I actually use physician by active ingredient fixed effects. So essentially physician age is essentially subsumed. I actually do include patient age as a control.
Yep.
I don't use non-chronic conditions in the medication adherence measures because medication adherence is mostly something we worry about for chronic conditions. But I'll think about this question a bit more. The 3rd one must have been, I at some point did use the definition chronic starter, but people found that confusing. I must have forgotten to take that out of the paper in one point. And then research question 3 and 4, maybe I could spend some more time discussing that. But so these are great questions, points. And so thank you very much.
Awesome.
I wondered, Peter, so both we can open it up to other people who, like David or Justin, who had questions in the chat with our remaining few minutes, but also I wondered you must have answered this big picture question a lot about how Belgium is different than other countries, not just the United States, but what's your normal pitch on external validity and what other countries might learn from the parameters you're estimating?
Okay, so I think that's a very good point. So I think the main takeaway I would kind of give, like the main elevator pitch that I had regarding this at least, was I don't necessarily see this as something fully externally valid in terms of pharmaceutical market for other countries. I do see this as a very unique kind of setting where I actually can infer from the data how patients and physicians actually behave, right? So because of a unique setting, I can actually fairly credibly argue what is in the physician fixed effect. And I can actually pretty credibly argue that if a patient doesn't show up to their pharmacists as regularly, that actually captures medication adherence. I do think where this is a very important question and has a lot of external validity is in the sense that especially this medication adherence is something that that is very difficult to actually measure in some other settings, and is something that is quite often not really thought of when people think about this research topic. So they typically look at stickiness in healthcare markets, and they argue this must either be willingness to pay for a brand name drug, or this must either be a physician agency, either on the physician side or on the patient side. I think what this paper kind of argues is that in chronic care, how patients actually use their chronic healthcare, and this is both for prescription drugs and actually other treatments as well. We actually really sometimes underestimate how behaviorally challenging this might be for patients. And as chronic care actually covers about, I think, 75 to 80% of healthcare spending in most countries I've looked at, including the US, and in that respect, Belgium and the US are actually very similar. This is a pretty important factor that we don't often take into consideration when we discuss just changing patients from one treatment to another.
Thanks. David, do you have a question, follow-up question?
Yeah, I just wanted to follow up a little on what I put in the chat. So you mentioned about a cap on the 25% coinsurance. How often does that bind? I'm just thinking about, I mean, like the American cases, like, you know, prescription drugs wind up being crazy costs and all the reimbursement coupons and all the nonsense around that. You know, how much of this is people figuring out through their doctors how they're actually going to save money? How much is the patient margin really small and this is just a provider insurance interaction? Maybe you give a little more color around this.
So I actually don't have a specific number off the top of my head where they actually hit the maximum bill. I could actually maybe look this up. I think to some extent the physician interaction, so definitely a lot of the pricing, the discussions are essentially done at government versus healthcare system level. And yeah, I would maybe need to think about that question a bit more. There's actually lots of impact there. Maybe one thing that I actually now also remember that Katie brought up is that I actually didn't really find an increase in the use of prescription drugs. So it does trend up over time a little bit. But if you take that trend out, I didn't really see a whole lot of gaming on the physician side to suddenly start prescribing a bunch of antibiotics. How patients would want to figure this out, I don't have a good, like, I would need to think about that a bit more.
I guess the reason I ask is that, you know, as an American, like, I love the idea of a situation where there's this provider-insurer, I guess, interaction with the patient being mostly out of it. Like, if you could show me that, you know, 95% of cases, the 25% gets them close to the cutoff, the cap, even in generics, and the patient margin doesn't actually matter. To me, that actually makes it a cleaner, more interesting paper than if you were like, oh, actually, the generics, they're rarely meeting the cap and the brand name they always are, and there's a big patient margin. So I think, like, where that is and how big a force that is in your situation, I think matters a lot in interpreting the results.
No, but so patients pay 25% on the generic and on the brand name.
Right.
And essentially what happens is that there's a reference pricing system in Belgium where essentially a brand name can charge more than the generic, but then essentially the patient picks up most of that cost if they charge more. But apart from that, I would need to think about this a bit more.
Okay, great. Great paper. Thank you so much.
Thanks.